So our next speaker is Dr. Karen Mourtzikos, and she's a nuclear medicine physician and the director of molecular imaging at Zwanger-Pesiri Radiology, where she oversees the PET MRI, PET CT, and general nuclear studies. So welcome, Dr. Mourtzikos.
Thank you so much. This is truly a privilege, and I'm so honored to be participating in this. I think it's such an important and worthwhile endeavor. Certainly a lot of people put a lot of time and energy into it, and I'm very grateful for the invitation. My overarching goal in speaking with you today is really to explain some of the imaging that is involved in diagnosing and kind of finding these tumors. So we're going to be talking about neuroendocrine tumors. I'm going to talk a little bit about kind of the radiological aspects of it, and then I'm going to spend a lot of time talking about the morphologic aspects of it, and the physiologic aspects of it, looking through nuclear medicine. So what we're going to do is kind of explain a little bit, just one quick brief slide. You guys know a lot of this stuff, and then we're going to get right into the imaging features. Cliffhanger. Nope. There we go. So yes, baby steps. I have no actual or potential conflict of interest in relation to this program. I think it's important to state that. So we're going to be talking about the background of NETs. Again, that's going to be brief. We're going to talk about morphologic imaging, so radiograph, ultrasound, computed tomography, which is CT, and magnetic resonance imaging, which is MRI. Again, just kind of general background so everybody understands what pictures are being taken and perhaps why. And then the majority of the talk is going to be about the physiologic imaging of NETs. We're going to talk about OctreoScan, and then we're going to talk about PET scans and some of those details. Those are kind of the more hot topics, if you will, as it pertains to this. So away we go with the backgrounds. So we know there's well-differentiated NETs that are either low or intermediate grade. We know the index and the anatomic imaging. And one of the important things that I would like to emphasize is kind of in this section, which is the functional imaging. So for the most part, when we're talking about well-differentiated, kind of low to intermediate grade, we're talking about OctreoScan and we're talking about PET scans. As these tumors come across and become poorly differentiated, they become more aggressive. So that's a little bit of kind of counterintuitive. So if something is poorly differentiated, it's actually becoming more aggressive. So you remember that is an inverse relationship. So when we get to that point, they become positive in a different type of PET imaging that we'll talk about. So again, there's kind of surgery and then observation or kind of going towards the aggressive route. And certainly there are several different tacks in terms of both systemic treatments as well as focused liver treatments, including radiofrequency ablation, embolization, TACE, and now serospheres. That's kind of the general whirlwind background. But if we talk about the morphologic imaging, a lot of times patients start with an x-ray, right? So you go to your doctor, you say something's not right, I don't feel well, we start with an x-ray. And that basically uses a small amount of radiation that comes from an outside source, right? The tech leaves you in the room. Anytime somebody leaves you in a room in radiology, you know there's probably radiation going on. So they leave you in the room, you hear a chirp, they tell you to stand in front of something, and that generates the x-ray. Kind of one step up from that is ultrasound. Ultrasound uses sound waves to generate images. So you'll go and you'll lay down, you have the study done, a tech will actually put kind of a probe and usually some level of cold gel right on you, and that probe's called a transducer, and that gets information about the structures in your body, and it's very focused and targeted, and it uses sound waves instead of using radiation. Next up is usually a CT, a computed tomography, and that also uses external beam radiation. It's usually a short, brief test in which they'll do often chest, abdomen, pelvis, and then that's a great starting point for a lot of patients who are kind of going through this step that you guys go through to figure out what's going on, what's next, and then also in following. So that gives information about what the tissues and structures in your body look like. The difference between a CT and an X-ray that oftentimes people ask is an X-ray is basically a two-dimensional image. You stand there, they shoot it, that's it. A CT is done spiral slicing. So if you think about how like a spiral sliced ham is, stay with me, this is kind of a weird analogy. But if you think about how a ham is spirally sliced and you have those thin things that can be put together, but if you kind of peel it apart, you can see that's exactly what a CT does. It kind of spirals through a person's body and gets thin slices so we can see what's going on in each slice. Now, the last piece of morphologic imaging we often use is MRI. The great thing about MRI, and I'm going to go into a little more detail about this in a few slides, is that it doesn't use radiation. And for those of you who've had it, it's the loud one. So what you go into a magnetic field, well, somebody will ask you probably 5 to 6 times if you have any metal at all on you, in your pockets. Like getting on a plane is a lot easier than getting into one of these MRIs because of the strong magnetic field. And while you're in that scanner and you're in that magnetic field, radio frequency waves kind of jar the magnetic field, and that's how we get the images, and that's when it's loud. So the MRI gives tremendous detail about soft tissue, and one of the important points that we'll come back to is it doesn't use radiation. So here was the cliffhanger, physiologic imaging. This is OctreoScan. A lot of people in this room have met OctreoScan. It may or may not be your friend. It's one of kind of the cornerstones of functional imaging that we use in nuclear medicine. So what is it? It's a nuclear medicine study performed by a gamma camera. And what's important about that, if you look at this picture down here below, which is a gamma camera, we have a head here and a detector here, but there's lots of space in the middle. And that's going to be important in a couple slides, remember this, when we talk about what the difference is between this gamma camera and a PET scan. So it's an imaging test that uses a small amount of radioactivity to look for disease within the body. One of the biggest differences between those 4 modalities we just spoke about and everything that has to do with nuclear medicine is those other modalities either use sound waves or magnetic fields or radiation. All of that is outside of your body. As soon as you come to the nuclear medicine department, we start injecting small amounts of radioactivity into you. So when we talk about morphology, it's like taking a picture of cars in an intersection. You can see in a still frame where those cars are. When we talk about nuclear medicine, we're actually doing that live camera feed, which depending on where you are on Long Island may actually look like a still picture anyways, because we all know how our traffic is. But what you can actually see are the cars moving. And so we get information about how these tissues are functioning. And so what we do is we inject that activity and it will give us specific information about the physiology, how those cells are working. So OctreoScan is similar to somatostatin. And everybody who lives with NETs knows what somatostatin is. So that it acts like somatostatin, and so it goes and it sticks itself onto tumor cells that actually have receptors for somatostatin. So right now in that sentence, you can see what I mean. An MRI is going to take a picture of something that looks funky in the liver. An OctreoScan is going to send a somatostatin receptor analog, something that looks like a somatostatin, to grab right onto that tumor. So it's more specific in theory. But as we say that, the sensitivity is about 75% to 100%. So that's tremendous if you happen to have an NET that likes OctreoScan and is interested in it. Then you're on that 100% side and you're great. A lot of people, however, say, I know I have NET, but it doesn't care for OctreoScan. So I'm 75% or below. So not all tumors are always detected with this. And I think that's kind of an underlying theme that patients who live with this disease and physicians who treat patients who live with this disease really understand well, is not everything acts the same, hence our zebras. So this is an example of what an OctreoScan study looks like. So this is a lot of fuzzy dots, and that's okay. That's what it looks like to everybody. And there's kind of a joke in medicine that nuclear imaging is unclear imagining, because what we do is we look at these fuzzy dots all day long, and so some of our medical colleagues have a little sense of humor about it. So this is a 67-year-old woman who has Zollinger-Ellison syndrome, and so you see focal uptake in the head of the pancreas right here, that big arrow is, and so that's where the primary is. This is another example of kind of this fuzzy imaging, and what we see is a 63-year-old woman with a carcinoid, and it's in the ileum, so that's right here. That's part of the small bowel, and you can see that there's activity throughout the liver and in the spleen, and then you see that there's also a lymph node and some other lesions as well as the lungs. But what's important about this is to understand kind of the quality of these images. So if you can kind of remember that OctreoScan is, it's a somatostatin analog, so any tumor cells that have somatostatin receptors on it, this is going to run and jump on it. However, it's taken with a camera that has just 2 heads, so there's lots of space to lose information, and not all of the neuroendocrine tumors are interested in it. So let's talk about a PET scan. All right, let's see how that's different. So PET stands for positron emission tomography. That's a detail that you may or may not need to know. Everybody knows it as a PET scan. So similarly to an OctreoScan, PET is an imaging test that uses a small amount of radioactivity to look for disease within the body. And there's 2 types of studies that we do. There's 2 types of radioactivity that we inject into patients. One is FDG, and the second big one is DOTATOC. There's kind of cousins to DOTATOC, but I'm going to be talking primarily about DOTATOC today. So how is a PET scan different, right? Because we need to know, well, what do you mean by this? So the PET scan uses a full ring of detectors. So when you look at a PET scanner, it looks like a CT scanner. It looks like an MRI. There's a whole circle all around you that's going to be collecting information. We've injected you with the radioactivity. This energy is coming out of you, and it's going to get caught by this full ring of detectors. And that's different than when we were talking about the gamma camera. So the PET scan detects pairs. The way the radioactivity breaks down, there's always a pair. So the great thing about that, and why I even bother to mention it, because we all have other things to do on a Saturday afternoon besides learn nuclear physics, is that it has a higher sensitivity. It is a better picture. If the camera is looking for a pair of things happening, so it can detect where that pair came from, the images are better, and therefore the ability to detect smaller lesions, perhaps lesions that would like to hide in the body, all of that is better as a result of those differences. So again, an OctreoScan uses the 2 heads, and everybody can escape from here, and meaning some of that energy can escape from there, and you have a little bit of a fuzzier image. If we talk about a PET scan, it's a full ring of detectors. We're looking for paired images, and then this is the quality of the images that we can see. And you can certainly see a difference here in the lungs, and you can see all the additional lesions that we're able to see as well. So how can you use a PET scan? We talked about 2 different types, main things that we inject in patients. F18 FDG, so we call it like colloquially or commonly called FDG, is FDA approved, it's widely accessible, it's covered by most insurances. The big challenge in NETs is that it's not specific for it. FDG is what I call spy sugar. It's a sugar molecule that has basically had one of its groups pulled off and a radioactive guy stuck on. So to your cells, this looks enough like sugar to get into the cell. Once it's in there, though, the cells realize that this is a poser, this is an interloper, and they can't use it. However, it's a little trickier, spy sugar, because it doesn't let the cell kick it out. It's like that relative that kind of doesn't really leave after dinner's done. Like you can't actually get them back out. So what happens is any cells that are hungry, any cells that are dividing faster, cells perhaps that are fighting infection, that are healing, they need more energy. So they're going to keep taking up more and more of this radioactive sugar in the hopes that they can use it. Now, having said that, FDG is great for a whole big long list of other cancers. The challenge in NETs is that sometimes NETs are a little snobby. They're like, yeah, I don't really care for your spy sugar. I don't want any of that. I'm good. So the problem is that when that study is negative, we're not sure if it's negative because there isn't active NET. Maybe it's negative because the NET is being snobby and it doesn't want that FDG. It doesn't want that spy sugar. So a lot of patients aren't really sent even for the FDG PET because if it's negative, you don't really have an answer. So one of the cons is that it's nonspecific for NETs and its sensitivity starts down at about 76%. So it almost starts at the same level as the OctreoScan. So if you're positive, that's great, but we know a lot of patients are not. If you remember from way back, that first slide I showed you, poorly differentiated NETs sometimes are a little more interested in the FDG, but that's not where a lot of people sit. And then again, still, you're kind of like, don't know if you care enough. So gallium DOTATOC, the pros, it's very specific. And again, we're using these in the PET scanner, right? So these are two different agents, general and now specific. So it's specific when diagnosing NETs. The sensitivity starts at about 96%. So at the end of that study, we feel confident saying that if there's active NET, there's a very high likelihood that we've seen it. And if you think about a study or a test, that's kind of the one you want. You say, okay, I'm going to go ahead and have this study done, but at the end of it, I want to feel confident that I either have it or it's not likely that I do. Like if you're done and it's a shoulder shrug, you're kind of like, well, I didn't really need to do that to begin with. The FDA, however, has it kind of under orphan drug status. So that's kind of a good thing, but it's also one of the challenges. It's not widely available. I know it's kind of like a buzzword in this community, like the DOTATOC. Have you heard the DOTATOC? You get the DOTATOC? Who's got it? It's difficult to obtain. So with the orphan drug status, you can do an IND or an investigational new drug, and then you kind of need that first step in order to approve it for use. And anybody who's done this, and we are one of the groups that have done this or in our process for submitting our application, can tell you this is a tremendous amount of work, an awful lot of paperwork, and it can really take months to be approved. So our process has been going on since about August, I would say, as Dr. Gerstein is not counting the seconds and glaring at me right now. Yes, we have been trying to do this since August, and it has really been a challenge. And one of the biggest cons, of course, is that it's not currently covered by insurance. So what happens is the PET study, the actual camera time in that study will be covered by insurance, but patients often are asked to pay for the DOTATOC out of pocket. So that's kind of the general takeaway from this slide. FDG is not readily always usable in patients with NET. DOTATOC is, but we certainly are facing some challenges. One of the other important things to think about with this is there's two different ways to get a PET scan. So we said, okay, you can have a PET scan, and there's two different things that we can inject in you to get those images. In addition, though, there's two different ways to get a PET scan. It's either a PET CT or a PET MRI. And I imagine that a lot of people who've kind of gone through these steps are certainly aware of PET CT, but you may not be as aware of PET MRI. It's fairly new in the US. So PET always has to be stuck with something. What does that mean? When you are injected with the radiopharmaceutical and those pairs are coming out of you into that ring of detectors, it all sounds great, and it is. However, some of those pairs are going to get lost. They've got to make it out from your body. They may bounce off the rib. Maybe there's a little more padding because we didn't winter well, and then it doesn't make it out. There's a loss of this information. So PET is always paired with its friend, either CT or MRI. And what those do is they help to make those pictures better. So the CT is used for anatomic localization. So it helps to say, hey, you know what, I think that focus came from the liver. Well, maybe there's somebody close to the liver. Is it really the liver? The CT acts like a map to tell us that's where that is. In addition, the CT helps to correct those images and make them better. We can't inject huge amounts of radioactivity into people. We think it's the wrong thing to do. We inject small amounts, and then we use other things to kind of improve those images. And so that's what we do here. MRI is an imaging test we talked about that uses magnetic fields and radio waves to capture images, and it's used to investigate or diagnose conditions like tumors, joint or spinal injury diseases, soft tissue injuries, or disease of the internal organs. MRI is great in telling us about our soft tissues. It gives us lots and lots of information. So for example, some of the other benefits, so MRI has no radiation, it has better soft tissue contrast than CT, and it has more potential to give us more information. That's a whole lot of words there. Basically, that says you can get more information out of an MRI. So this image is actually an image of someone's brain, kind of sliced this way on a CT. And if I use the helpful pointer, you can see that maybe something is not right here. If you look at the MRI, you can certainly see where the lesion is, and you can see that there's swelling and all sorts of upset brain around it. This is not an NET patient. But the example that I use is to understand kind of how much more information MRI can give you. So, okay, so what's a PET MR? So Siemens has generously created this slide with our little automaton friend. who is going to have a PET MR. So what happens is the scanner acquires both the PET and the MRI